Good morning. I am Dr. Satyajit, Associate Professor, Department of Pediatrics. Today we shall be discussing a few of the very common instruments that are used in the field of pediatrics. To begin with, let's look at the lumbar puncture needle. The lumbar puncture needle basically has two parts. First is the needle and the second is a stillet that very snugly fits into this needle, and it has a lock, the lock which is visible here, and it gets very snugly fit into this needle. Like the word lumbar puncture, it is definitely used in the spaces of the L3, L4 or the L4 and L5. The lumbar puncture is done in a child in whom we suspect meningitis or meningoencephalitis. The child has to be kept in a fetal position in the left lateral position traditionally. In some cases, they can be also kept in a sitting position. Now that is done in babies in whom we can hold them in a sitting position where the backs become very rounded, and so doing the procedure becomes very easy. But there are several uses of this needle, namely diagnostic and therapeutic. Diagnostic meaning to test. Now, that is something which we all know. In a child who has a suspected meningitis, in such a child, once the baby is kept in that fetal position, very held in a proper position, the needle is inserted and there is a give way sensation. When that happens, this stillet is withdrawn. As you withdraw, you will see that this end of the needle gets filled up with the CSF. In a normal child, the CSF would be very crystal clear and would fall drop by drop. In a child who has meningitis, especially bacterial meningitis, there is a likelihood that this chamber gets filled with a purulent discharge, and then that is collected gradually. Once that is collected, it is sent to the lab to check for the cells, it is checked for the glucose, the protein. We also do cytology, basically to look if there are any malignant cells. For example, in the case of leukemia, we do suspect that there may be malignant cells in the CSF, because the CSF or the CNS is a sanctuary site. Which are the other sanctuary sites apart from the CNS? It is the testis. Okay, right. So the samples are sent. The other test that is sent is for the culture. The culture, of course, takes at least 72 hours to come, and therefore we don't base our treatment initially based on waiting for the culture report. The moment these cells come in and the moment we know that this is of a bacterial meningitis, the cause is of a bacterial origin, we start our antibiotics accordingly. If the child is sick, we don't even wait for that. The moment the LP is done, the antibiotic is started. A little more sicker child, we don't wait even for the LP to be done. We give the first dose of antibiotic, because that could be life-saving, and thereafter the lumbar puncture is done. Within this collection of the CSF itself, if you keep that sample aside, you will find a sediment that happens maybe after half an hour or so, and it forms a cobweb formation. That is a near hallmark of a TB meningitis. So in a case of TB meningitis, the proteins precipitate. They precipitate and then they form a coagulum, and that looks like a web-like formation within the CSF fluid. So that is a pointer that probably you are dealing with a case of tubercular meningitis. Therapeutic indications of the lumbar puncture includes in a child who has a pseudo tumor cerebri or benign raised intracranial tension. Now, this happens in several conditions like hypervitaminosis A, it can happen hypervitaminosis D, it can also happen is a sequelae of some of the vaccinations like hepatitis A. So this is all described. So in such a child, the moment you do the lumbar puncture, you find the release of the pressure very gradually, and the child's symptoms get relieved in a snap. By the time you have finished the procedure, you find that the child is completely relieved. Okay, so that is a therapeutic indication. The other therapy is a treatment is for giving intrathecal methotrexate. So intrathecal methotrexate is one of the chemotherapeutic regimens in a child who has ALL or acute lymphoblastic leukemia. Like I mentioned before, the CNS is a sanctuary site along with the testis. So these are some of the indications of doing a lumbar puncture in a child, very common indications. But mind you, even before doing a lumbar puncture, you must rule out raised intracranial tension. Okay, you get a fundoscopy done, rule out papilledema, and even if there is a slight indication to feel that there is a raised ICP, you must go ahead and get an imaging of the nervous system done. You have to rule out raised intracranial pressure. And if there is raised intracranial pressure, it is one of the absolute contraindications for doing a lumbar puncture. Now, if there is a doubt, okay, that means clinically the child seems to have features of a raised intracranial pressure, however the imaging doesn't reveal, then you are supposed to do something called a guarded LP. So in a guarded LP, the needle goes in and the stillet is very gradually withdrawn, such that the stillet, when it is just a little bit outside, when it is pulled a little bit outside, you find that the drops start to come. You begin to collect or you begin to release the pressure by letting the CSF fall out. So this is called a guarded lumbar puncture. Like I already mentioned, the places to use this or the sites to use this are the L3, L4 and the L4, L5. These are the very common sites to do so. The complications of doing a lumbar puncture is inadvertently, if you have not looked to rule out a raised intracranial pressure, there is a chance that the child may cone and even die. So you have to be very careful about that. Children who have coagulopathy, severe coagulopathy or bleeding disorders, this is a relative contraindication. The lumbar puncture is a relative contraindication. In those children who have thrombocytopenia, again the lumbar puncture is a relative contraindication. So the complications of doing a lumbar puncture is pretty clear. You may even cause a traumatic lumbar puncture. You need to be very careful. So the positioning of the baby and the site of insertion and the piercing into the lumbar space, into the LP space, becomes very, very crucial to get a CSF. So this is about a lumbar puncture needle. Let us go to the next instrument, which is the nasogastric tube or the feeding tube or the NG feeding tube. Now, this is how a feeding tube looks like. Okay, something that forms a very unique characteristic feature is a cap on the proximal end, and the entire length of the tube, if you can see, the entire length of the tube has got a lead line. A blue or a green or a black lead line goes across the entire length of the tube. There is a reason for that. Okay, this is a lead line and this is radio opaque. So that means when you insert this tube, you can detect or see as to the extent of the tube that is inside the upper gastrointestinal tract. So this will help you in that matter, right? Like I said, how do you identify this tube? You have proximally a cap, a lead line that runs throughout the entire length of the tube. At the distal end is extremely soft, okay, and you find bores on this side, okay, the bores on this side. You will not find a bore at the tip of the catheter. You will only find it on the side, right? So this is how you identify the tube. Once you have done, we should know what are the uses. You have diagnostic as well as therapeutic uses. The diagnostic utility is, once you can use this tube, once it is inserted, you can take out the samples and send it for toxicology analysis. So in a child with unknown poisoning, okay, not for corrosive, but for unknown non-corrosive poisoning. In a corrosive poisoning, this is an absolute contraindication. Do not do it, because you could actually rupture and puncture through the GI tract. So you don't want to use this. Similarly, in a child with kerosene consumption, okay, hydrocarbon ingestion, you don't want to do a nasogastric lavage, because the child may puke, the child may vomit, and the child may aspirate. There are several deleterious effects because the child would vomit, and that inhalation of that toxic substance may actually aggravate the problem the child already has. So you don't want to do it in that point of time. So like I said, the therapeutic uses and diagnostic uses. So among the diagnostic uses, you would like to send the early morning gastric lavage of a child in whom you are suspecting tuberculosis. You will send that for the ZN staining, that is a Zeal-Nielsen staining, to identify tuberculosis. We do it only in the morning hours because you would like to keep the tube the prior day night and collect the samples the next day morning to send for the ZN staining. So that is a diagnostic use. The other use that you have is therapy. So therapy, like the word itself says, nasogastric tube, you would like to insert and then give feeding in a child who is not able to take orally, in a child who is semi-comatose, in a child who is completely comatose, in a child who is on the ventilator and has to be fed. You don't want to keep the child nil orally when a child is on the ventilator, especially for prolonged periods of time. So this will actually help you for that. Now, how do you use this? How do you insert? How much? See, look at the tube. The tube is very, very long. So how do you insert? So what we do is we measure it from the ala nasi right up to the tragus of the ear, and from the tragus of the ear up to the xiphisternum. This much would be the length for me. Okay. So once again, from the tip of the tube which is kept at the ala nasi to the tragus of the ear, and from the tragus of the ear up to the xiphisternum in a continuation. That would be the amount that would be inserted inside the nose, through the nose into the stomach. Now, how do you confirm that this is inside the stomach? This tube is inside the stomach. Okay, at times the baby may be having coughing and vomiting, and then there is a little unsurety as to the tube is inside or it has gone the wrong way. The way to confirm ideally would be to get an X-ray, but an X-ray may take a little longer time. So you aspirate. Usually you do get the stomach contents, but at times if you get a frothy fluid, you are going to be confused. So what you can do is you can put in a bowl of water and see if it continues to bubble with the respiration, that means you are in the wrong way. You need to reposition. Okay. So the other way to confirm whether this is reached the stomach is to take a syringe and you keep it at the proximal end of the catheter. Okay. And then you just insert around 1 or 2 ml of air very quickly, and as you do so, you auscultate on the stomach end, and then you will find a gush of air that actually is released inside the stomach. So this is how you identify if you are inside the stomach. Like I said, the gold standard to identify if we are in the right position is by getting the X-ray done radiologically, right? Okay. So these are the uses. Now, are there any other uses? Yes, there are. In fact, smaller tubes, smaller French catheters of the feeding tubes can be even used as a urinary catheter for neonates. Okay, we don't have a Foley's catheter which is normally used. So a smaller French catheter, a smaller French feeding tube is used as a urinary catheter, and then this is the other end is kept inside a container, so you can measure. So that is about the feeding tube. Let's go to the next instrument. The next instrument is something which you can actually get confused very easily, and that is the suction catheter. Okay. Now there is a marked difference. I am going to use both to compare. A difference in this catheter from the prior catheter that I showed you. Now in the prior catheter that I showed you, which is the nasogastric tube, you find a cap. A big difference. Here there is no cap because this is a one-time catheter. You just do a suction and you discard it. The other difference that you find in a suction catheter is that there is no lead line. There is no lead line across this tube at all. The other thing that you find as a difference is that the suction catheter has a bore at the end, which is not present in a feeding tube. Okay, so these are the few distinct features of a suction catheter. Now, why is it so? A suction catheter is not meant to be indwelling for a long time, whereas a feeding tube would be remaining inside the stomach for a longer period of time, maybe for a few days, at times even 5 to 6 days, up to a week. Whereas a suction catheter, like I mentioned, is a one-time suction catheter in the sense that you do a suction and then you just throw it away. You don't preserve it and you don't reuse it. It is not meant for that reason. And that is why there is no cap and there is no lead line also. Okay, so this is a suction catheter. This is the parts, this is how you identify. The contraindication of doing a suction would be a bleeding disorder, and if the child is hemodynamically very unstable, you don't want to do a suction at that point of time unless it is a dire necessity. There is a lot of blood coming out, you want to keep the oral cavity clear. Yes, it is only at that time you would like to do. Otherwise, you would not like to do a suctioning. A suction should not be unnecessarily done. Only if there is a strong indication of a lot of secretions, thick secretions blocking the airway, it is only then that you would like to use it. So that is about the suction catheter. The next instrument we would like to discuss is a bone marrow needle. So bone marrow needle is a very tough needle, very tough needle. At times, because looking at the length of this particular needle, there is a chance you may mistakenly say that this is a LP needle. But look at the LP needle, it is ready to bend, okay, but not a bone marrow. It is very strong. A bone marrow needle is extraordinarily strong. So there is very little reason to actually get confused with other needles. Very strong, okay. Right, now these have the following parts: a cap, this has a needle that is seen outside, and then a stillet, okay. So in the stillet is a blind stillet, meaning that there is no bore to that particular stillet. So it occupies the entire length of the needle. Now, these are the parts. In a smaller baby, we have another type of needle, which is a bone marrow. The only difference being there is a guard. So the guard will tell you as to how much length you would like to move in. So this can be adjusted in this way. Okay, that is the only difference apart from the length. So this is used for older children, adolescents, or maybe on an older child, and this needle is used in smaller infants and babies. Okay, you have a guard, so you don't want to penetrate too deeply and go across the marrow. So that should not happen. So that is the basic difference between the two needles that you have, the adolescent and a small child or a baby, right. So what is the site? Where will you use it? So the sites of using a bone marrow needle very commonly are the anterior superior iliac spine, posterior superior iliac spine, iliac crest. Very common. Now this is for older children. For smaller babies, you would like to use it on the tibia. You look for the tibial tuberosity, keep a finger space below, and on the medial side, you find a very big flat surface. It is there that you actually can drill. Fortunately, that space remains very prominent even in neonates, and that is exactly the place where you will be using this particular needle, even in a neonate. Okay, right. So what are the indications? Well, you have again therapeutic and diagnostic indications. So what is the diagnostic indication? So when are you going to think of doing a bone marrow is when you have an anemia whose cause is not clear. So refractory anemias. Okay, you want to think of storage disorders. For example, in Gaucher's disease, you may get a Gaucher's cell lying inside the bone marrow. You may have in diseases like HLH, hemophagocytic histiocytosis. In that, you may get those Langerhans cells sitting right inside. Okay, you will be sitting inside those histiocytes inside the bone marrow, and that is where or when you will be using them to diagnose. So the sites I have told you, in smaller babies I have told you in the tibia, on the medial side of the tibia, one finger space below the tibial tuberosity. Some even use it on the lower medial malleolus as well, but these are the common sites to use. So these are the diagnostic indications. Now for therapy, for diagnostic, of course, even for a case of ALL, you would like to do the bone marrow so that you can very easily find out and confirm a diagnosis. You may get a blast in the peripheral smear, but many times you may miss, because after all it's only a fluid biopsy, a blood biopsy, a one-time small sample. But the bone marrow is a place where all these cells are being produced, and so you can actually capture these cells very easily. The therapy, remember these needles have another very crucial role to play. It is a life-saving device. especially when the IV lines are not got easily. They can be used for IO, I.O. That means intraosseous. Intraosseous meaning osseous is bone, intra of course through. So this needle can be used the same way, the same procedure is used. Only thing is we remove the cap after it is inserted inside the bone, remove this particular stylet, and here you will attach the IV set and allow fluids, blood products, all sorts of medications that can be pushed in until you get the IV peripheral axis or maybe a central axis in the neck, that is the jugular vein or the subclavian vein. So this is a very, very crucial apparatus, should be present in every ward, in every ER, in every place where a child is going to be managed. Because when a child becomes sick, say a child is in shock, you don't get a peripheral vein access, very thready pulse, you don't get an access. In such a child, you would use this needle, the bone marrow needle, for IO axis or intraosseous axis. So it is an extraordinarily very crucial instrument, should be present in every tray. So is there a contraindication for this? When I said it is life-saving, it should be present everywhere. Yes, that is true. But then, in a child who has osteogenesis imperfecta, that means a brittle bone disease, the bone is so brittle, the moment you start using this needle for a purpose, it's going to crumble. It is going to break and fracture into fragments. You don't want to use this. You cannot use this. In fact, you will be causing more harm than good. In a case of coagulopathy, severe bleeding disorder, also you would not like to use a bone marrow aspiration technique at that point of time. In a child who is hemodynamically unstable, say severely hypotensive, the child can actually bleed and die to death. So you don't want that procedure to be done at that point of time. Once the baby or the child has stabilized, his vitals are relatively fine, only then would you like to do this particular procedure. So that is about the bone marrow needle. The next instrument that we shall talk about is yet another very crucial apparatus, and that is the ambu bag. As you can see, this is the ambu bag. Okay, so an ambu bag is the artificial manual breathing unit. It has an outlet and it has two inlets. The outlet gets connected to a valve and an outlet device. Okay, this outlet device has a pop-off valve. The pop-off valve is, say someone uses a lot of pressure, huge pressure, the excess air gets released from this pop-off valve. So that is a safety valve, right? At the same time, oxygen that is inside this bag is delivered through this piece, and from here it gets attached to the mask through which it is delivered to the baby or the child. Now, I have told you that the inlet has two orifices, of which one should be connected to a device called reservoir and the other would be connected to the oxygen inlet. We all know what oxygen does and what its use is. So oxygen will actually fill this particular bag, but there is a problem. Once you squeeze the bag, okay, once you squeeze the bag, the oxygen that is there in this bag gets delivered to the baby, and when you release it, it sucks in the room air. Room air is what? 21%. So this 21% gets diluted or mixed with the oxygen that was already in the bag and brings it down to as low as 60 or 55%, which in many places may be very suboptimal. You require the bag to have at least 100% oxygen. To prevent or to increase the oxygen delivering capacity, this reservoir is used. What happens is the oxygen fills this bag and fills this particular corrugated reservoir in such a way that when you squeeze, 100% is anyway delivered. When you release, the oxygen that was there in this particular reservoir gets sucked in, maintaining 100% oxygen that would be always delivered. So that is the role of a reservoir. So this is an ambu bag. This is the outlet device to which there is a pop-off valve, and that device is connected to a mask. Okay, so this is an ambu bag. So the indications of this is of course life-saving for resuscitation. It is used for neonatal resuscitation, and bigger volume bags are used for resuscitation in an older child. So respiratory failure. Respiratory failure is the primary indication. Okay. You also want to pre-oxygenate children whom you are going to ventilate. So even that is done with this kind of a device. Now you must have already noticed that this bag has a spring action. So it is a self-inflating ambu bag. A non-self-inflating ambu bag is the one that is present in the OT or the operation theatres. Okay, you must have seen it is a bag that collapses, a black color or green color bag that collapses, and it requires oxygen to fill the bag to actually get inflated. Whereas this is a self-inflating, meaning that the moment you squeeze and you release, it gets back to its normal shape. You don't have to do anything further, and it is ready for use again. So is there any contraindication for this? The probably only absolute contraindication for using a bag and mask device is congenital diaphragmatic hernia. The reason being, the intestines are all present, half of them are present inside the hemithorax, and once you start doing an ambu bag device is used or a PPV is used, you find that this air, this oxygen goes in not only into the lung, it goes into the GI. Like I said, the bowels are present inside the chest. This air would enter the gastrointestinal tract, would fill this intestine, and this would begin to push the lungs to the opposite side, making it hypoplastic, and that is dangerous. Already one hemithorax is filled with intestines. We don't want the other functional lung also to get damaged and compromised, and that is why the congenital diaphragmatic hernia is the absolute contraindication for using an ambu bag device. So that is about the ambu bag. Let's now talk about the mask. So there are basically two types of masks. One is the round mask, the one I am now showing to you. So this is all age kind of a mask. You just have to see that it fits properly. The other one is the traditional triangular kind of masks. Anyway, any mask that you are going to choose should be such that it be appropriate for that particular patient, baby or child. Now how do you choose an appropriate size mask? Now an appropriate size mask would be one which would cover the lower part of the nose and upper part of the chin. Once that is done, it should occupy and seal completely in such a way that there is no leak of oxygen or air from the sides of the mask. Okay, how do you hold this? You keep a C-shaped clamp on the mask from above, and then these three fingers are kept in a E shape, okay, in such a way that this clamp is kept on the face, and this would be keeping these three fingers on in the shape of E, alphabet E, would be kept on the chin, and a mild head tilt towards up in such a way that the airway is kept straight and patent. You thus ensure that the baby gets a continuous airflow and your resuscitation is an absolute success. Else, if the neck is kept flexed, okay, you will not be able to ensure your resuscitation to be a success. The airway is not going to be patent and the baby will not be revived. In fact, the child would deteriorate faster because of your improper positioning. So that is very dangerous. So you must ensure a proper positioning of the neck. Right. So that is how the masks have to be used and chosen. The next thing that we would like to discuss is the laryngoscope. So a laryngoscope basically has a few parts, and they are the handle and the blade. Okay, these seem to be the most crucial parts, the handle and the blade. Okay, you can see that there is a clamp into which you need to put this blade and just pull it in. You can get a clicking sound, okay, and once that click sound is there, you extend it. Once you extend, you find the light coming out, and that means you're in contact. But the general dictum for the usage of a laryngoscope is what we tell from generation after generation is do check the batteries behind. What happens is the battery that is kept in the back is not positioned properly. Okay, to save power they are kept in opposite directions. So that has to be ensured. So whenever you have a laryngoscope and you are called for an NRP, which is a neonatal resuscitation program that happens or that has to be done in the labor room or say in the ER, you need to ensure that the batteries are kept properly and they are in good condition. The lock of the blade is done very nicely, and then when you extend it, you get a light, and then your laryngoscope is ready for use. Okay, it is ideally used in the opposite dominant hand. Okay, in the sense that if you are a right-hander, the blade should be held in the left hand. Okay, once it is held in the left hand, you need to see that the tongue is lifted properly so that the vocal cords are visualized, and then the tube is supposed to be inserted. So there are basically two types of blades that are available for use. So one is the straight blade, it's almost straight, right? And the second is the curved blade. Straight blade is more than enough when you use it for a neonate or for a very young infant. Okay, in an older child, once the baby is a toddler, okay, is a toddler and older children, definitely there is more air passage, it becomes longer and it is more curved, a longer tongue, the tongue has to be lifted, you need a curved blade. Otherwise the usage and the handle locking facility on the laryngoscope is all the same. There is no change. You just need to insert it here in this way, hook it on and extend it, and here it is. Your laryngoscope is ready for use. Okay, so that is how you need to use the laryngoscope and its blade. Again, what are the uses of a laryngoscope? So a laryngoscope would actually complement when you are using the endotracheal tube, and this is used in cases of respiratory failure. So in a child who has a respiratory failure, okay, or say let's take a neonate or even a young baby. In such a baby, the blade is kept ready. You extend the neck a little, lift the tongue, and then the next apparatus that would be used is the endotracheal tube. Like I said, it is a non-dominant hand, so you lift the tongue up, and then as soon as you visualize the vocal cord, the endotracheal tube is actually inserted. Okay. So this is the basic usage of a laryngoscope. We go to the endotracheal tube. So in the endotracheal tube, you will find that it has both the ends that are open. You find the proximal end, which is actually a uniform bore, okay, and you will find a tube which is entirely lead lined along the entire length, meaning that this is a indwelling tube. The end of the tube has a thickened black mark. Okay, so this black mark would mean the amount of the tube that needs to be minimum inside. Okay, if you are able to see this during intubation, after the completion of intubation, it means you are precariously out, you need to probably go in a little more. Okay, so this will help you as a guide. You can see that this tube is a little curved. It takes the direction of the air passage, which is a little curvaceous, and that is why the blade as well for an older child is a little bit curved. At times, this tube needs to be inserted with the help of a stillet. Okay, because the airway can be directly visualized and your tube may go in and turn away. A stillet will make this a little straight, okay, and so it helps you to very easily go in. Otherwise, what would happen is if you hit any structure on the side by chance, it may actually bend away. So there is a small likelihood. To prevent that, you can use a stillet. For older children, you can also use an apparatus called a bougie. So this will help you to guide and enter the vocal cords. Now, how do you know you are inside the vocal cord successfully? If there is a lot of debate among you and your colleague or assistant to say that no, we are not in through the vocal cords, we are not in the trachea, instead we are in the esophagus. What would happen is you will find a lot of gastric secretions coming out. The moment you attach this to an ambu bag in this way and you start bagging, or you give a lot of positive pressure ventilation, you will find that the abdomen gets distended. well, that itself is a very major indication that you are not in the right track. And if you are inside the trachea, when you auscultate both sides of the hemithorax, you should be able to hear very good air entry. If you are not able to hear it, then there is a problem. If you are able to hear it only on one lung, on one side of the chest, well, it means that you have intubated and gone through to one side of the lung, into one of the main bronchus, either it's the right main bronchus or the left main bronchus. You need to pull your tube back, okay? Pull your tube back till you hear the air that is auscultated well in both the hemithoraces. So this is how you actually know that you are in the correct space. Again, the gold standard would be to get a capnograph done through this. So once you attach this, you know the CO2 levels, and if the CO2 levels are in the desired range, you are well inside the tract, you are well inside the trachea. The other way to confirm whether you are too much in or you are too out is to get a X-ray done, a bedside X-ray. Ideally, you would like it to be in the interclavicular space, okay, on the X-ray. So once you have intubated, you must get a chest X-ray done. It may take a little while, but then it is worthwhile. You must get a X-ray done. So this is how you need to identify the tube, and this is how you must insert, and this is how you should identify whether the placement of the tube was good or not. Let's go to the next instrument, which is a Foley's catheter. So Foley's catheter is basically inserted to ascertain the urine output. It has basically two inlets and one outlet. This is the proximal part. The proximal part has the place where the stellate, when it is taken out, is attached to the catheter. The other inlet is for pushing in air to see that the balloon at the distal end gets inflated. For example, once you have inserted and you are sure that you are inside the urinary bladder, you need to fill this up. You need to push in air. Once you push in air, you will see that the distal end begins to inflate. Once you have inflated the distal end, then you have locked it in. Then you don't have a problem. This tube will not come in. So using a syringe, you need to push in air, and then you need to see that this balloon here, it inflates. Once that happens, then the tube will be pulled a little bit so that it snugly fits in there, and this tube will not come out. This is not having any radiopaque line and will not be visible on any kind of a radiological device. So in which conditions, what are the indications for measuring a urine output? Well, in children who have AKI, that means acute kidney injury, in children who are in shock, hypovolemic, septic shock, or shock of any reason, you need to have a clear urine output. In conditions, in children who are comatose or semi-comatose, you do not know if the intake and output are adequate, you need to measure. In children who have low GCS or Glasgow's coma scores of less than 8 and 9, you need to measure the output using a Foley's catheter. The advantage of this is it is self-retaining. This tube won't come out. For example, like I told you a while ago, if you use an infant feeding tube in a smaller baby, because this is not available, there's a big chance that this tube may actually come out because it doesn't have any system of retaining itself within the urinary bladder. Okay, so this is about the Foley's catheter. Let us go to the next apparatus, and that is a syringe. Well, a simple syringe is something which is known to everyone. It has basically two parts. So one part is a piston. This is the piston and this is the main syringe. So we all know for sure that this is used to draw in medications and administer. Okay, it has a nozzle end and then it has a piston end. Okay, right. Can this be used in any other conditions is another question. Yes, it can be. In fact, you can cut this part of the nozzle end, reverse the piston, and then it is used in mothers who have a retracted nipple and they have feeding problems for a neonate. Okay, so this syringe can be used for that as well. The syringe comes in different amounts or volumes. They come as 5 ml, 10 ml, 20 ml, 50 ml and even 100 ml syringes are available. So it is up to you to choose which amount of volume of a syringe you need to use. So this is used basically for therapeutic and for diagnostic. Therapy, yes, you have to give lots of medications. In fact, even feeding, you attach this to a NG tube. Okay, once it is attached to an NG tube in this way, okay, feed is put inside this and then feed is allowed to run in. So this is called a gavage feeding. Okay, you would not like to push in the feed, you would just like to fill in the syringe with the feed, and then you can see it gravitate downwards towards the stomach. So that is the use of a syringe for a therapy. Now for a diagnostic use, yes, you can actually attach, you can draw blood. So once you have attached this to a needle, the needle is inserted inside a vein, and then you know we can do a phlebotomy. You can draw in blood and that is sent for sampling. Toxicology samples or all sorts of samples, we are all totally aware. The similar thing we also do is for taking the gastric analysis sample. Okay, the same thing can be also used for inserting the amount of the fluid inside the Foley's catheter to see that this is sufficiently distended at the opposite end, just like this, it gets distended. Okay, so these are the uses of a syringe. Let's go to the next instrument, which is a tongue depressor. So there are basically two types of tongue depressor. One you have is the traditional old time metallic reusable tongue depressor, and the other is the disposable wooden spatula. So it is an L-shaped structure, and if you see, the proximal most end has a hole for the little finger. Okay, so this end goes inside the oral cavity. In a small baby, it becomes very difficult to use this, in the sense that a child is going to struggle, becomes irritable and may injure. This is metallic, so this can injure the lips or the structures inside the mouth. To do away with that kind of a problem, we have a wooden spatula. This is much more easier to use, smaller, convenient, and not metallic, so does not cause injuries to the extent that a metallic one would actually cause. So where do we use this? Whenever you have a pathology to be seen in the oral cavity, for example dental caries, to look for conditions like you have Kawasaki disease, to look for tonsillitis, posterior pharyngeal wall abscess, you want to see for quinsy, you want to look for any congenital anomalies like cleft palate, you have to use this kind of a instrument. To look for patches on the tonsil like a diphtheritic patch, or maybe a patch secondary to infectious mononucleosis, or maybe because of a fungus, you have to use this kind of an apparatus. Now, is there an absolute contraindication of using this? And the answer is yes. You should not use in a child who has croup, C-R-O-U-P, or a laryngotracheobronchitis or epiglottitis, to be more specific, because the moment you use this, the child is going to get very agitated, and the child's vocal cord may go into full spasm, and the child can actually virtually choke and die within minutes. So that is why you would never examine the oral cavity in a child who has a croup. Croup is a inspiratory stridor, so in that kind of a child you would not like to use this. So that is about the tongue depressor. The next we are going to talk about is about the true cut liver or a renal biopsy needle. In a true cut liver and a renal biopsy needle, we have a Wilhelm-Silverman needle or a biopsy true cut gun kind of a needle. So the indications would be in a child who has a liver pathology which is not diagnosed easily, or you want to classify some kind of a renal pathology, the disease of which you already know. Now, In a child who has a cirrhosis and the cause is not known, you would like to do a liver biopsy. In a child who has probably a probable diagnosis of Wilson's disease, you would like to do a liver biopsy in a child who has ICC or Indian childhood cirrhosis, which is now rare. In some conditions, you would also like to know the amount of iron, the dry weight of iron in the liver. In such children also, you would like to do a liver biopsy. Now, in children who have a probable Wilms tumor, a mass arising from the kidney, you would like to use this needle. To do a biopsy of the kidney. In children who have a nephrotic syndrome, a very difficult refractory kind of a nephrotic syndrome, a resistant kind of a nephrotic syndrome, you would like to know which type of nephrotic syndrome it is, whether it is which kind of a non-minimal change disease. A non-minimal change disease is a common type. So whether it is a crescentic type or a proliferative type, you would like to know by doing a biopsy. In children with SLE, systemic lupus erythematosus, you would like to know what is the grading of the lupus in the kidney. So this becomes very important at that time. Most of this has to be done under anesthesia because the child will move, and in case the child moves, it is going to cause bleeding. Most of these procedures are now done with the guidance of an ultrasound. A real-time ultrasound will guide you to go into the structure and get out than going in blindly, which can cause more damage and can cause bleeding. The absolute contraindication of doing this kind of procedure is a child who has an unstable hemodynamic status. If the child is in hypotension, you don't want to do it. The child is in severe respiratory distress and child is having unstable vitals, you don't want to do a biopsy. In a child who has coagulopathy and bleeding disorders, you don't want to do this. Once it is stabilized, you can go ahead and do a biopsy of the kidney or of the liver. The next instrument I would like to discuss would be the rotahaler. So the rotahaler is this apparatus. It has again an outlet and an inlet. An inlet is a place where you will be putting the rota cap. Once the rota cap is inserted inside this chamber has a capsule breaker. This is inserted in, and then as you rotate, if you can see, this capsule breaks and falls into this chamber. The child is asked to put this particular device in his oral cavity and his mouth and inhale it deeply, not just once, maybe 3 or 4 or 5 times, till the powder completely vanishes from this chamber. Well, what is the way that the child would know that the system is being done properly or the procedure is being done properly? You need to advise to tell him that the capsule that breaks into this apparatus would start moving in rapid rotations. You can hear that sound. Okay, that would tell you that the drug is probably getting administered effectively to the child. For this, the child's cooperation is mandatory. That means a child younger than 7 to 8 years may not be able to do this properly. For such a child, the device to be used is not a rotahaler, but then it would be a metered dose inhaler. So in a rotahaler, we use a DPI or a dry powder inhaler device. So a rota cap is used. So this is the use of a rota cap. This is used for types of asthma. Most of them are chronic asthma. In acute asthma, the child gets tired out and therefore will not be in a position to use this. MDI would be a better option. So that is the use of a rotahaler. In a child who is having an MDI, which is otherwise known as a metered dose inhaler, you have a canister and you have device proper itself, which is L-shaped. Now, in a child who is older than 8 to 10 years of age and has good voluntary control, you can ask him to directly take it into his mouth. So you ask him to blow the air out, keep it into his mouth, and as soon as you press the canister down, okay, you ask him to inhale and then hold his breath for around 5 to 10 seconds, rapid 5 to 10 seconds, and then breathe out. Thereafter, you ask him to rinse his mouth so that the drug that is delivered, if it is deposited in his oral cavity, will be rinsed and flushed out. So that is the use of a metered dose inhaler. Now, in a child who is younger than 7 years, can we use it? Yes, the answer is yes. For such a child, you have something called a spacer. So a spacer can be used to a baby as small as even 8 months and even 10 months. You don't need the voluntary control at all. Now that is the biggest advantage that we have while using this apparatus. So this is the rotahealer. Okay. So in the rotahealer, we attach the MDI to one end here in this way. Okay. And to the other end, we attach the mask. This is a very silicone mask and it is attached in this way. Now this is kept to the oral cavity and then you actually press. You press the canister. The canister, as soon as it is pressed, releases the drug into this chamber. The mask has to be kept onto the face very snugly. There shouldn't be any gap around, and then you ask the child to breathe in and breathe out inside into this particular chamber itself. Now how do you know whether the child is able to get the drug, and how would the parent know whether the child is getting the drug? Well, there is a valve here, if you can see, a blue color structure which is a valve. Okay, a blue color structure which is a valve. Now that would begin to move with each inspiration or expiration that the baby takes or the child takes. That means that the drug is getting delivered into the child. So that is the way you use it. So for a young child as small as even a year old to even an older child, even 5 year, 10 year, 12 years, yes, you can use it along with the spacer and the mask. In fact, it would be safest as an option to advise using a spacer and the mask along with the MDI to ensure that the drug that you have prescribed is being delivered and the compliance is good. Else the child will come back with exacerbations and we would be puzzled as to why your therapy has not worked. Again, you can use this even in acute severe asthma. That means whenever there is an exacerbation, the child need not come running immediately and waste time in that process to the hospital. What you need to do is use it along with salbutamol. Okay, use the salbutamol beta agonist and continue to tell the mother to deliver those puffs using the spacer and mask, because the child would be panting, the child would be tachypnic, the child would be in distress. Ask the mother to put this onto the face and continue to deliver the medication. Okay, so that is the use of a MDI. The next instrument that I would like to talk about is the oropharyngeal airway. So now this belongs to a small baby, so it looks small. So oropharyngeal airway, as the name suggests, is to be inserted in the oro and it goes right down up to the pharynx. Okay, if this is to be inserted to a baby, okay, you need to keep it the opposite way, this way. Insert it upwards. As soon as you nearly touch the upper palate, you turn it clockwise or anti-clockwise and allow it to go in fully. So where can you use this? You are supposed to use a oropharyngeal airway only if the baby or the child is comatose. Do not use it in a semi-comatose child. You will be causing more problem. To avoid or to circumvent that problem, you will use a nasopharyngeal airway in a child who is semi-conscious or is conscious, and you still need to maintain the airway. So that means if a child has a airway that is getting blocked because of the tongue fall, in a comatose child, yes, you may probably use an oropharyngeal airway. But in a child who is semi-comatose or a child is conscious and is having a tongue fall for some reason, you can use a nasopharyngeal airway. Once that is put, then you can use your ambu bag and mask and give positive pressure ventilation, and then you can ensure that the oxygenation is delivered. So that is the use of a oropharyngeal airway and nasopharyngeal airway. The next thing that I would, or the instrument that I would like to talk to you about, is this scalp vein set. This is something that is a very, very, very old and a common instrument that is used. A few decades ago, this was the only probable instrument available to draw blood and administer drugs. But the problem of this is it has a metallic tip. A metallic tip would mean that this would counter the vessels through and through, in the sense that it would perforate the vessels and the vein would be lost. You would have to again find out another vein. To circumvent this problem, the invention of the IV cannula became very useful. Okay. So then, is this ever used? Yes, it is used. It is used for sampling blood. Okay. The moment someone holds a hand, or maybe from the cubital fossa, this scalp vein is inserted and it is sampled. In fact, in preterm babies in whom veins are very difficult to get, and sometimes you may get it on the scalp, okay, you can actually insert it in some of those very superficial veins and be very successful, because those preterm babies or those term babies will not shake their head much, and this would be very easy to stabilize on the scalp. So this is the use of the scalp vein set. The next thing that we would discuss about is the IV cannula. This is what I just mentioned, that when you use the IV cannula, you find that it very easily fits in to the vein. IV cannula is basically invented to circumvent the problem of a scalp vein set. Now we shall discuss about an IV cannula. So an IV cannula was basically invented to circumvent all the disadvantages of a scalp vein set. Like I mentioned before, scalp vein set is a very old instrument. To circumvent that problems which were being faced with the use of a scalp vein set, an IV cannula was invented. So the IV cannula has the following parts. You have basically a stillet, you have a plastic needle, a plastic sheath, and then that stillet is attached to a chamber. So the moment this enters, the cannula is inserted inside a vein, this particular chamber gets filled with blood. Thus, it ensures that we understand immediately that this particular cannula is in the correct position, and we need not do anything but just fix it onto the part that you have inserted. So that is how a IV cannula works. Now the biggest advantage, like I told you, is once the stillet is taken out, you find that the sheath is completely plastic. So any movement on the wrist or any part of the body will not allow this particular cannula to get dislodged, unlike that of the scalp vein set. Like I had mentioned, the scalp vein set is having a metallic needle as compared to a plastic sheath that the IV cannula has. Now, how else can we modify this, or how else can we improve the function of an IV cannula? So once the IV cannula is secure inside the vein, we could attach something called a three-way set or a three-way stopcock. So this is a three-way stopcock. Now once this is attached to the cannula, this can be locked on and more than one fluid or drug can be administered. So this is the advantage of using a three-way stopcock along with the IV cannula. So this is a very genuine apparatus which becomes extraordinarily helpful. You can give medications, blood products, drugs of resuscitation and multiple other fluids at the same time. So this is the advantages. The sites mostly are in the peripheral, in the extremities, but in some instances when you do not get an IV access in the periphery, in the limbs, you would like to cannulize the one of the central veins, for example the external jugular vein, which becomes very easy to fix and navigate through. Thank you. I hope I have covered almost most of the instruments. There may be still many more, but then these are the most common instruments that are used in pediatric practice. Thank you.